All right, I'm going to talk about infection control maintenance. Maybe call it infection prevention maintenance. And I'm comparing my experience working with pharmaceutical facilities and working with hospitals. Pharmaceutical, I've always admired how they're very proactive with quality control because they're very concerned and boast about having 0 defects. And I don't usually hear that term from the healthcare side. So the pharmaceutical people have a focus on investing so that the product going out the door has 0 defects. And they know from their own experience that if there's a problem, it stops the flow of the product, re-engineering, repackaging, whatever, but they know it costs money. With the hospitals, and I work with a lot of facility groups as well as design, the product going out the door is a healthy patient, and yet we have this ongoing healthcare acquired infection. So it's really not a 0 defect goal in the healthcare side. And I hear talk about this risk versus cost. Well, the pharmaceutical knows what the risk is, and they're willing to put in the cost. And I don't feel that's the same way with healthcare because I know a lot of facilities are really good, but others, the facility people feel like a necessary evil, and they're in the process of trying to do the best they can. So I give you a little experience. My experience is, in addition to the design side, I had the opportunity to be on a quality control steering committee and learned an awful lot about quality control. And I'm going to talk about that process with the idea that if we rethink how the maintenance is done on infection control or infection prevention in healthcare, we could maybe improve it by creating a single source group focused strictly on infection prevention. And so clearly there's progress with reducing infections, hospital-acquired or healthcare-acquired infections over the years. I think some of that, though, under the surface has been driven by regulations and penalties because money talks. And so they'd have the sole responsibility and accountability to do their job without the distraction of making sure that fan casing isn't leaking and so forth, other work orders. And so to embrace the 0 defects, I think is a culture change that would take a page out of the pharmaceutical group. Because the pharmaceutical is definitely profit-driven, and they realize quality control is value-added. They know that from their own experience, and they've invested in a lot of time and money that they feel is worth it to strive for that 0 defect goal. And so their 0 defect goal, as I say, is the product going out the door. And I believe in time that that could be a goal that could be very achievable with healthcare. Now I'm told from some that certain areas of hospitals have achieved that 0 defect or 0 hospital-acquired infections, but it's not the whole hospital. And so if we rethink it and remove some of the silos of tasks and consolidate the infection prevention into one work order system with a select few people who every day live and breathe infection prevention, I think that it might be an initiative to, as I said before, take us to the next level in reducing the healthcare acquired infections. And anything less is expensive, and say the pharmaceutical people know that very well. So my suggestion is this infection control management department, and it would be made up of select few people who are doing the actual work. Sure, you'll have an oversight group of all these other departments, like it was just presented earlier, to maybe a steering committee as a fresh pair of eyes to help this group. But their day-to-day requirements are to tackle anything associated with the potential for the infection prevention. And this group would have a vision that is built on quality and zero defects. And it would result from accountability. They're the ones who are responsible for this. And the mission to do that would be an infection prevention work order system. And if any people are familiar with the work order systems, you collect a lot of data, you can now start to monitor and measure the results and continually improve on this. And the reporting just is a byproduct. You'd be able to, it's like with any computer program, you have a spreadsheet of information, you can sort it any way you want for the benefit of whoever wants that particular report. So that's my vision of how this would start. The group is probably a year off before that happens, because I talk about quality. Those who have been involved with quality training, quality control isn't just a statement. There's problem-solving tools and initiatives. There's statistical analysis, ways to calculate the benefits and identify what the deficiencies are. And Philip Crosby who was one of the gurus of the quality control back in the late 80s and 90s, had the 4 absolutes of quality management. And quality is conformance to requirements. And I'll tell you a story about my cousin who went into a hospital, a major hospital on the East Coast, for a major operation, and I went and visited a few times. And I noticed a couple of things. She was in a patient room, there was 2 patients. She was near the door, and all the traffic going up and down the corridor, like Tracy talked about having I call it an airlock, because pharmaceutical people, they're concerned with contamination in a different way than infection, but they're concerned with contamination. Any important area, they would put an airlock. And so if there was an airlock to this patient room, it would cut down on all the activity out in the corridor. And the corridor looked kind of dingy because it was really poorly lit, so it just looked dirty. The other thing was the medical staff coming and going into the room. I never saw them once follow their hand hygiene policies. And they'd go to my cousin, and then they'd check on the other patient. They'd go out, they'd pick up this, touch that. It never occurred. The one thing they were really good at, and in regards to conforming to requirements, they were good with the barcode. They had a barcode scanner, and every time they had to issue something, they'd take the bracelet and scan it. I don't think they missed a beat with that barcode scanner. And I just thought, well, they prove you can conform to requirements, but you got to buy into it to do it. And they were not doing that with the infection control policies and procedures. Unfortunately, my cousin died, I guess it was about a month later, from a hospital-acquired infection. And there's other stories like that. But if you just watch people going around, You'll hear they're understaffed, they're working long hours. There's all these things that are very valid. But if you look at what is the product going out, a healthy patient, they're not contributing to that. It's such a broad topic that you really can't just go down one track and think that's going to solve everything. You have to really get together with the hospital staff, the various departments, and kind of walk through this way to developing the plan. As important, and this can be started sooner than finding the ultimate group. You work on a work order system that you start pulling in all the pieces from the different silos that have to do with infection, control, maintenance. And you start pulling those tasks together and creating work orders. And when you do that, you eventually standardize the work order. Say it's an infection prevention work order for an air handling unit. It could be the same kind of thing for medical equipment. So you start to create these work orders, you standardize on them, and these work orders, if you're not familiar with them, you itemize the tasks, you put timelines, like it'll take you 5 minutes to do that, and 10 minutes to do that. And you identify, well, this has to be done monthly or semi-annually or annually. And it comes up with the estimated time, and at the cost of an employee doing this, you can create a budget, a portion of the budget of what it's going to take for this department to function. And a standardized checklist is just another form of quality control. You take that checklist and you'll continually improve upon it. Because the technician will go out there, they'll do certain things, they'll come back and say, you know what we don't have on this checklist, this task, and they'll suggest something. So you're continually improving on that. It's also, with that data coming back, you want to monitor and verify that the work's being done. So a person in charge would take randomly, say, 10 work orders, go out to the equipment with whoever did the work orders and visually inspect it, just to make sure they're not just checking off the box. And so you monitor that in that fashion. And you collect the data, you analyze it, and you're able to report on the work success. Collectively, through the computer, you can shuffle it around and sort it and say in any which way, so you know what has been done, what appears to take a lot longer to do, and you can say determine that, analyze it, and improve upon it. And it's a means to update and continually improve the management performance. And it's also a method to compare past to present results, and you want to publish that information. One of the things that I know facility people, if there's not a problem, they don't say anything, and so they never get credit for a job well done. You only hear about the facility is when something's wrong and they're complaining about the department not doing something. We did a evaluation of a major hospital, and we found when somebody would call in to complain about something, they'd send a technician up. More often than not, the technician went up, the person who complained was at lunch or wasn't working that day. They'd either fix it or they'd say, okay, I'll get a part and I'll come back 2 days from now. We simply got, like on the hotel door, it says, you know, do not disturb. We got these cards that you put on the doorknob saying, and they'd fill it out. It was a standardized card saying something like, you know, certain tech was there, looked at the problem, did this, waiting for a part. But because the tech may never see that person again, or not for a week or two. And meanwhile, the person's saying, well, they never come up here anyways. So you do that as a customer satisfaction thing. The other thing you do is pharmaceutical people do this. They'll put it right down the corridor, a 4x8 storyboard. And they'll start with the WV diagram, and they'll say what the theme is. In this case, why can't this facility have its own standalone infection prevention department for maintenance? And they'll put pertinent information in on this storyboard all the way up to some of the results to say, we had no record of work orders before, now we know that we did 85 this month and we have 3 more to do, but we're waiting for parts. But it gives the rest of the company, or in this case the hospital, the ability to see, oh, is this what these people do? And it's also good for when you're doing something specifically to infection prevention. You have not only the patients, but the visitors coming through and in the hallways. They see these storyboards that basically, without telling them, you're highlighting what you're doing for infection prevention in this hospital. So it's self-serving in many ways, in that fashion. So the infection control management department, which I call infection prevention management department, it would make up those groups, and I put down some of them, that do work orders for repair. And you draw from these groups into this group, and their whole job, again, is simply to do work orders associated with infection prevention. And out of that, you'd be developing your policies and procedures to be adhered to. And you'd be doing the proper monitoring, measuring, and reporting needed within the department to know what they're doing and how well they're doing, needed within the hospital for others who want to know how this is coming along, and then needed for any regulatory issues. So with this vision of a single source solution, this group would be the sole responsibility for the infection control or infection prevention work order system, focus on anything that would require a work order, so that you could consolidate all that, take it from the various departments, put it into one department, where that single point would be accountability. And it just shows for the people in there that that's their job, and that their responsibility is strictly that, so that there's no other distractions, that it's 100% work effort to that particular initiative. And the whole process would be driven, and you teach these people through quality control, ways to analyze the problem. They come across new problems, they'd be able to put a team together, work on coming up with a solution, so it would be a very quality-driven operation. And I guess the bottom line is that I go back to the pharmaceutical. They've been doing it for a long time. They invest an awful lot in operation maintenance. They don't like to spend money on it, but they will. It seems the personnel have better training as a whole, and I guess it's because of the commitment by the pharmaceutical people that they're concerned with their bottom dollar. And so with healthcare, I think it would help elevate that whole operation maintenance performance to a new level if they were to sort of learn from what the pharmaceutical industry does and be more cost effective in the process as they go along. With that, that's my vision. I was making up time. We on track now?
minutes late.
All right.